Welcome to this series of lectures in oral medicine, this one entitled Orofacial Pain. This is a second of the series. You would have had some basic orofacial pain previously, but we're talking here mainly about chronic orofacial pain. Chronic pain is pain that's been present for more than 3 months. And this diagram by Robert Merrill et al. Indicates how we can split the diagnosis of orofacial pain or head pain into musculoskeletal, neurovascular, neuropathic and psychogenic. So broadly, musculoskeletal is muscle problems, joint mechanics, arthritis. Neurovascular is migraine, other primary headaches, tension type headaches, autonomic cephalgias. Neurogenic is peripheral neuropathic pain, neuralgias or central neuropathic pain. We probably won't dwell too much on the psychogenic area, which is somatization disorders and psychotic disorders. So prevalence of orofacial pain in the general population, according to Benoliel et al., is about 17 to 26%, of which 7 to 11 are of a chronic nature. Chronic pain is defined, as mentioned earlier, pain present for more than 3 months. So if we look at this diagram, again, when you're dealing with pain, it's very important to get a long and good history description of the pain. And with musculoskeletal, the pain level is moderate, suggested to be moderate or described in that way, moderate to severe in neuropathic and severe in neurovascular. Description of pain often is suggested to be pressure pain in musculoskeletal, electrical or burning in neuropathic, or throbbing in neurovascular. Distribution, usually it's anatomical, it can be bilateral. Neuropathic, it's dermatome related and usually unilateral. Neurovascular is unilateral as well. Other associated, there may be dysfunction, difficulty in mouth opening and so on. With musculoskeletal. With neuropathic, there's sensory changes, and neurovascular might have autonomic changes as well. Some examples of musculoskeletal temporomandibular disorders. Neuropathic is trigeminal neuralgia, atypical as well, trigeminal neuralgia, burning mouth syndrome, and traumatic trigeminal neuralgia. Neurovascular, migraine, chronic paroxysmal hemicrania continua, and cluster headaches are some of the examples. When you look at pain diagnosis, make sure that you look at the location, the latency, duration, frequency, trigger and aggravation, behaviour, quality of the pain, accompanying symptoms. Temporomandibular disorder, TMD, was introduced, included into the differential diagnosis of craniofacial pain in 2004 by the International Classification of Headache Disorders, and this was an important step because it meant that more research funding could be achieved by those wishing to study this disorder. Dentally trained clinicians should, though, initially make sure that they rule out any dental or oral causes of pain, such as tooth pain, mucosal and periodontal disease, sinus pain, and possibility of tumours. Beware of other common possibilities. Example, ear problems and eye problems can refer to the oral region. So, musculoskeletal pain, let's look at the review the TMJ anatomy. We know that it's a ganglion more arthroidal joint, referring to its dual compartment structure and function, and it has a hinging as well as a gliding movement. In the hinging movement, you get about 2 centimeters of opening. In the gliding, you get the extra 10 millimeters or 1 centimeter. So a normal opening would be greater than 30 millimeters of opening. So you've got the glenoid fossa, the articular condyle with the disc in the middle to prevent bone from rubbing on bone, and the disc will go with the condyle in its opening and closing movement. So in the gross anatomy you have the disc here. The disc would normally be in between the condyle here and the fossa, and you've got the ear canal here. In a cadaver dissection here you see the disc and the head of the condyle with the muscles attaching into the appropriate areas. The upper head of the lateral pterygoid will attach into this area, and the lower head will attach to the inferior part. Posterior band of the disc and the intermediate zone and the anterior band. And from a front view, then you get it's like a schoolboy cap, and the articular disc and the lateral pole as seen here, and the medial pole on the inferior aspect. So if you look at the actual disc, you have an upper and lower joint cavity, superior and inferior, and it is these compartments that when we are doing arthrocentesis that you inject liquid into that compartment to wash it out and take it out again, take the liquid out again. So you insert two needles, one injects and the other one aspirates. So with the movement of the TMJ, it's like a schoolboy cap. Initially you get rotation of the condyle, no movement of the disc, and then you get forward translation of the condyle and the disc, and then maximum opening. Both condyle and disc are forward. So in this you can see the cadaver on the left and the live person on the right with that schematic to show where the condyle and the disc will be on opening and closing back to normal. So we need to also, with dealing with pain, we need to look at remember that the sensory innervation of the temporomandibular joint is derived from the auriculotemporal and mesenteric branches of mandibular 5. Arterial blood supply is external carotid, superficial temporal branch, and some contribution also from deep auricular, anterior tympanic, and ascending pharyngeal and maxillary branches. So, as with anything, when we're managing the patient, you have a procedure to go through. Presenting complaint is very paramount, and our main role is to find out what is troubling the patient and help them alleviate that as a priority, except in a life-threatening situation. The history and symptoms, this is also very important, the single most important step in helping you arrive at your diagnosis, especially with chronic pain. If we go back to our diagram, remember the descriptions, and remember for pain diagnosis you need to go through and record the answers to all these questions. Extraoral, obviously, we might start with palpation of the nose and salivary glands, look for muscle tenderness on the temporalis, on clenching and release, joint sounds and tenderness on mouth opening, mandibular movements, lateral and opening, and cranial nerve function may be looked at. Intraorally, presence or absence of teeth, condition of the teeth, they are present, periodontium and mucosa, salivary gland content and consistency, presence of or signs of bruxism or abnormal tooth wear, muscle palpation, masseter and pterygoid. Then you might carry out some special tests such as, I think an OPG is mandatory to rule out any other associated pathology or unrelated pathology. A CT scan or MRI and blood tests may be also required for a full diagnosis. Transcranial and OPG are mandatory. MRI can be 27 to 30% inaccurate due to disc fibers being orientated longitudinally and circumferentially, but often an MRI is needed if you are wanting to look at a disc rupture or other soft tissue components. So presentation, a TMD, temporomandibular disorder patient may present with uni or bilateral facial pain, ear pain, tinnitus or fullness in the ear, headaches, frontal, temporal or occipital region, Eye pain described often as retroorbital or periorbital pain, pain on chewing or yawning, inability to open the mouth wide. There may be joint sounds on mouth opening and closing. Extraoral check for signs of general health and nerve function, one or all, tenderness of temporalis muscle, masseter muscles, tenderness of TMJs, mouth opening less than 3 centimetres with or without pain, pain on lateral mandibular movements, palpate nodes and salivary glands. So intraorally exclude dental or mucosal pathology, tenderness of masseter and lateral pterygoid to intraoral palpation. Also, you should check the neck muscles. Radiography we've already talked about, blood test and then diagnosis. Imaging can sometimes bring up other pathology, such as in this MRI scan shows a parotid gland hemangioma. An OPG allows you to have a look at the TM joints, the sinuses, any pathology in the mandible or maxilla, or any periopical pathology with the teeth if they're present, or any other pathology that's present. You can also get a good view of the condyle and the fossa, and in the case of an arthritic situation you would see notching or the edges of the bone not being so demarcated. Management generally involves conservative advice and self-help exercises, occlusal splint therapy, which is still one of the main ways of helping patients control their pain problem. Physiotherapy and or massage, medication. Usually, my opinion is that medication should be used on a short-term basis. Arthrocentesis for those recalcitrant problems. Surgery also is a possibility, especially in those situations where there has been joint destruction, so joint replacement may be required. Counselling, because we're talking chronic pain, and as pain becomes more prolonged and chronic, then the patients undergo some psychological changes. So remember that jaw reception requires 4 components: muscle spindle, Golgi tendon organ, TMJ capsule and periodontal ligament. So the periodontal ligament also is involved with the jaw reception, and therefore this may be a reason why splints work, and because often we have to adjust the splint, and what you're doing is creating different contacts and different impulses from different periodontal nerve fibers, and therefore you're creating a distraction, and this relates to the gate control theory. So if we look at the latest research, we know that the OPERA study, orofacial pain, prospective evaluation and risk management, came up with this diagram where you've got a painful TMD, and that could be persistent TMD, transient or subclinical signs and symptoms. And they may be, there may be a high state, the person may be, have a high state of pain amplification due to endocrine function or changes in endocrine function, autonomic function, impaired pain regulation or pro-inflammatory state. So these things can actually change a patient's state of pain amplification. High psychological distress, mood, anxiety, depression, stress response and somatization can be a factor involved with maintaining that pain. Then on that you've got environmental contributors such as physical environment, social environment, cultural beliefs and demographics. Male, female, we know that females perhaps have less descending inhibition of pain, therefore that could explain why females feel pain more. But most importantly, we are now also looking at the genetics, and there are, especially the COMP gene, the so-called pain gene, certain haplotypes of the COMP gene are more prone to feeling pain. So you've got, what we've got now is a genetic component that indicates that someone is going to be more prone to getting a chronic pain condition, and you put them through certain environmental contributions and psychological distress, and then you've got a painful TMD condition. Neuropathic pain, by definition, is pain initiated by a primary lesion or dysfunction of the nervous system. Primary, where there's no recognised pathological process. Secondary, where there is such as post-herpetic neuralgia. Orofacial neuropathic pain, Benoliel et al. Coined that phrase. You can have continuous, where you might have burning, such as in post-herpetic or burning mouth syndrome. Paroxysmal, such as trigeminal neuralgia, where you get short electrical or sharp pain. Peripheral sensitization, the neurons become unusually sensitive and develop spontaneous pathological activity. So basically, when you are continually stimulating the peripheral receptors, then they eventually start firing off by themselves without stimuli. And this is called peripheral sensitization. In a similar way, the central receptors can, through peripheral sensitization, undergo sensitization, and that is called central sensitization. So basically, the mechanism is you've got an impulse will come along the axon, and where the receptor is, you get neurotransmitters that swim across that gap basically and propagate the nerve impulse on the second order neuron. And so you've got peripheral receptors that need to be stimulated, and neurotransmitters need to be formed to send the impulse along the first order neuron, and then the same thing at the receptor between the first order and the second order. You also need to have neurotransmitters to propagate that impulse. So when you get these, usually this process occurs through normal stimulation. But when there's peripheral or central sensitization, you don't need that stimulation. It's happening by itself. So you get ongoing pain. This is a complicated diagram just showing how the first order neurons come in to the ganglion and through the spinal cord up to the higher cortex. And here in this diagram, you've got it's almost like a joint capsule and fossa, but you've got the nerve, one axon coming and synapsing with another, and with the receptors playing a part. Neuropathic pain affects 1% of 1 to 1.5% of the population. There are reports of larger amounts. A further study in the UK on the epidemiology of 4 neuropathic conditions, including post-herpetic neuralgia, trigeminal neuralgia, pendulum limb pain, and painful diabetic neuropathy, found an overall prevalence of 83.8 per 100,000 persons per year. So with trigeminal neuralgia, you can have a classical and symptomatic. Classical, which is previously called idiopathic or primary, may be related to neurovascular compression, so a blood vessel compressing on a nerve, creating the pathology. Symptomatic, previously secondary or atypical trigeminal neuralgia, up to 30% may be in this category, present with some but not all diagnostic criteria, and it's more refractory to treatment. So the pathophysiology could be that it is the compression of trigeminal root at or near the Dres zone by a blood vessel or other lesion. Imaging is usually positive in 78% of the cases, and it's due to demyelination caused by the compression. Neuropathic pain can be very difficult to treat, with only some 40 to 60% of patients actually achieving partial relief. Based on current evidence, carbamazepine was the drug of choice, and a controlled release of formulation has fewer side effects. If carbamazepine causes side effects, then you can look at reducing the dose or baclofen added. Oxcarbazepine is another member of the same family, which suggests to have less side effects, and it can be used as an add-on therapy with lamotrigine. In refractory cases, gabapentin is a more recent drug that's shown a lot of promise, and pregabalin, Lyrica, is a newer drug that has also been effective. So the antidepressants, we don't prescribe the antidepressants because these patients are depressed. The antidepressants also have an effect on those neurotransmitters by blocking them, and therefore blocking the nerve conduction, as I explained before. And this is just for your completeness. You can just look at how they may work, but you can use topical agents, Botox or botulinum toxin type A can provide some pain relief up to 14 weeks. In some neuropathic pain syndromes, crosstalk occurs between descending sympathetic nerves and ascending sensory nerves, and this increase in sympathetic nervous system activity may result in an increase of the actual pain. This is known as sympathetically mediated pain. So lesioning operations on the sympathetic branch of the autonomic nervous system sometimes have to be carried out. Traumatic trigeminal neuropathies, possibly following third molar surgery, and you might get tongue dysesthesia and dental nerve damage in 0.1 to 0.3 to 1%. It could happen after endodontics, successful endodontics. 3 to 13% may cause neuropathic pain, or 5% after endodontic surgery. Implants also, there's with more and more people doing implants, it's going to be a high incidence of neuropathic pain amongst that. So now we go on to types of neurovascular pain: migraine, cluster headache, paroxysmal hemicrania, and other variants such as icepick headache and hemicrania continua. Basically, migraine affects about 16% of the population, more common in females, again, and genetic factors may be involved and usually develop in the first 3 decades of life. An aura may be present. Prodrome may be hours or days before the migraine, and that might be mental slowness, depression, irritability, restlessness, euphoria, and may last up to 60 minutes. Visual aura, or zigzag lines or flashing coloured across the visual field, or blind spot or sensory symptoms may also be present. Severe throbbing, debilitating pain with phono or photophobia may occur. Patients often have to lie down in a dark room. There may be nausea and vomiting present. Pathophysiology is that it's probably to do with the trigeminal vascular system, where neural innervation of the intracranial system is stimulated by neural and neurotransmitters, leading to a cascade of events that starts the pain. Triggers may be food such as hot dogs, MSG, red wine, and other such as alcohol. And management involves patient education to avoid the triggers, obviously, non-pharmacological to maintain a normal routine, relaxation, pharmacologic abortives such as non-steroidal anti-inflammatories, ergotamine, preventive such as calcium channel blockers, such as in terms of 5-HT, or inhibit vascular muscle contraction, cardicem, serotonin antagonist, methotrexate, which blocks the development of neurogenic inflammation, tricyclic antidepressants, which increases the availability of synaptic serotonin or noradrenaline by inhibiting the uptake. An example of that is amitriptyline. Trigeminal autonomic cephalgias, these are primary headaches such as cluster headache, paroxysmal hemicrania, hemicrania continua, and SUNCT. SUNCT is short-lasting unilateral neuralgiform headaches, attacks with conjunctival injection and tearing, so tears forming. So these are associated with trigeminal pain autonomic signs, that's lacrimation and rhinorrhea, and it's usually often rhythmical. So it may happen at the same time every day. It may be 4 o'clock in the morning. It's a quite classical presentation. So this diagram from Benoliel et al. Shows you that cluster headaches, the distribution with cluster headaches, paroxysmal hemicrania, SUNCT, hemicrania continua and migraine, which can have a crossover. So they're usually unilateral. Cluster headache is less common than migraine, also called migrainous neuralgia or Reader's syndrome. Affects men more than women, so this is one condition that affects men more, and usually in the 20 to 50 age group. No significant hereditary factor. They develop quickly and peaks in approximately 9 to 10 minutes. Intense, excruciating, deep pain. May get paroxysms of stabbing, like an ice pick, periorbitally. As usual, and unilateral, and is accompanied by ipsilateral lacrimation, so tearing and nasal drainage, runny nose. Lasts for about 30 minutes to 2 hours, and pain commonly occurs at the same time, example 2A. Diagnosis mainly from the history, management, patient education, avoid triggers, biologic clock, so maintaining good sleep patterns, non-pharmacologic compression of superficial temporal artery, pharmacologic oxygen at 100% or ergotomy will be curative or controlling. Paroxysmal hemicrania, it's more common in women, more frequent attacks, 10.8 mean and 48 hours. Shorter duration, lasts 2 to 30 minutes, peaking in 5 minutes, and which 13.3 minutes compared to 49 minutes for cluster headaches. And this one is responsive to indomethacin, which is diagnostic, and you just give 25 to 250 milligrams per day. So a summary of facial pain, we talk about pain level, description, distribution and other, and I've indicated some methods of treatment. With psychology of pain, we talk about Axis 1, which is the biomedical model, which is what you are used to in dentistry. Someone comes in with pain and there's a physical cause of the pain, example, carious lesion. Axis 2 is the psychiatric model, which is the non-physical or non-physically apparent. And then a combination of the two, Axis 1, Axis 2, is the biopsychosocial. So psychological influences on pain perception may be related to cultural factors, past experiences of pain, mood, fear, anger, depression, gender and sex. We talked about the fact that females feel pain more, and that's probably because they have less descending inhibition. So pain is a result of ascending impulses, and the brain sends down descending inhibition to that. If that's equal, there's no pain. That's why all of us can sit down or walk around, otherwise we'd be in pain. Context in which it occurs is also important, and beliefs about the pain. So fear can generate anxiety, and the more the patient focuses on the pain, then the worse it appears to become. Therefore, as pain becomes chronic, then anxiety increases. Therefore, you need to treat the anxiety as well as the pain. Perception of pain, understanding the psychological effects. So in this diagram is just to get you to understand that what you see sometimes is not what you perceive. And here what you're looking at is two parallel lines, and if we superimpose this pattern over that line, all of a sudden those parallel lines don't look parallel anymore. So it's same but different. So there is evidence that these patients undergo physical changes that can be attributed to what clinicians have previously labelled as this patient's a nutter. So, you know, a lot of patients unfortunately in the past have been labelled as a nutcase and dismissed, and this is a dangerous thing to do. So if we look at the biological factors, as we looked at that initial diagram, involve genetics, autonomic balance, allostatic load, fitness level, nutritional status. Behaviour, so principles of learning, interpersonal skills, relaxation, cognitive regulation, and so you get a bio-behavioural model where you've got biological, social and psychological interaction. But this is an old model, and I think that I will give you an indication of what I think is happening now. But there is strong evidence based base for cognitive apparent behaviour therapy, relaxation training and graded exercise for chronic back pain. But there's minimal evidence base for this in chronic facial pain, but I think that relaxation and cognitive behaviour therapy is important. Moderate evidence for hypnosis in both back and facial. Strong evidence in both for EMG feedback. So must think in terms of simultaneous treatment, not serial treatment. So the new suggested model is biological, genetical and psychosocial interaction to create the right environment for someone becoming chronically pained. Thank you very much.